All right, so hi Lindsay. I'm quarantined by myself, so I guess I'm just gonna kind of talk through and demonstrate these techniques as best I can on myself. So I'm gonna start with some of the postural correction techniques. The first one being cervical extension. So what we'll do for that is we'll cue the patient to take a deep breath in as they extend, and then to have a forceful expiration on the way down. So it'll look like the next one would be scapular retraction. So what we'll have the patient do is we'll cue them to bring their elbows back, squeezing the shoulder blades together, and we'll have them take a deep breath in, and then cue expiration on the way down. So it'll look like same thing for the next one. It'll be shoulder flexion. So it'll look like this. And what we're going to do is we're going to cue the patient to take a deep breath in as they bring their arms up. And they'll blow it out on the way down. The next techniques for positioning. The first one was supine with a bolster, such as a towel or a foam roller. I've got a foam roller here. What we're going to have them do is they'll lay supine, and we're going to position this kind of along their thoracic spine, just behind like this, and they'll lay over that. And what that's going to serve to do is it's going to open up that anterior chest wall, allowing for more volume, more room for expansion of the lungs with inspiration. The next would be the sideline position. So we'll use a bolster for that. If there's a side that's got some restrictions or some poor movement, or maybe like a condition's only affected one of the lungs more so than the other, we'll put that side up and they'll lay over top of this, and that'll serve to open up that side of the torso or the trunk. Other techniques we discussed were some myofascial release, so some kind of like cross friction, kind of to break up any adhesions or just soft tissue that's not quite moving well, that may be like restricting rib movement. So accompanied with that, we could have like PA glides in the 3 to 4 range to restore mobility up the thoracic spine. Also just some gentle rib springing. I don't have anybody here to demonstrate on, like I said. Other techniques to increase mobility through the trunk and thoracic spine would be the PNF pattern. So you would have D2 beginning here, coming out like this, or D1 coming here and coming up like, oh, nope, starting here and coming down like that. So D1 and then D2. Other forms of positioning were the prone on elbows. So I would have the patient, they would be supine on the ground. We would have them prop up like this, and it's gonna allow for better upper chest expansion. So I would cue them to take some deep breaths in like this. They can hold that position for prolonged periods, get relief, feel like they're getting a better quality of breath, better ventilation. The other would be kind of related to the postural corrections that we talked about. Just general posture correction, so sitting upright, allowing more room for expansion with the lungs. And the other was tripod position. So I'd cue the patient to begin in an upright position, take their hands, place it on their knees, come over into this tripod position, and I would cue them to breathe out, forceful expiration here. And that's going to allow for better utilization of those accessory muscles of expiration, the abdominals, to really get a forceful contraction and help get that air out. Obviously, that'd be most useful for some type of obstructive lung condition. Another technique we discussed was the butterfly technique. So we'll have them in that seated upright posture, cue the patient to put their hands behind their head. What we're going to have them do is we'll cue a big breath in as they bring their elbows back, and then cue forceful expiration on the way back in. So it'll look like The lower costal breathing was the next technique, also known as diaphragmatic breathing. So the progression for this begins in the supine position, progressing to a seated position and then a standing. I'll go ahead and demonstrate here in a seated, but what I would cue the patient to do is to place one hand on their chest and one hand on their stomach. I'd cue them to take a big breath in, and that the goal of the technique would be to feel that belly button or that stomach push out into their hand more so than their chest. And I could cue this by encouraging inspiration through the nose. So it'll look like that could be hands. We could apply some resistance to that, but any type of pressure through the stomach kind of provides a source of external feedback for them to work against. It can aid in the activation of that. And then obviously progressing from the supine to the seated to the standing, and then incorporating that into functional tasks, whether that be walking, lifting, whatever the patient participates in. The next techniques was the exhalation techniques, pursed lip breathing. So what that's going to be similar to diaphragmatic breathing, at least for the inspiration part, is we're going to cue breaths in through the nose, and then to purse their lips together, creating a smaller hole for them to breathe out. So this is going to create a smaller diameter for that air to be coming out of. It's going to create a longer time or rhythm of exhalation and a more forceful expiration. So I would cue and then kind of building off of that was paced breathing. And what that is incorporating that same technique, that pursed lip breathing, and setting it to a rhythm during activity. So we would cue inspiration for a count of 2, expiration for a count of 4, and they could be taking steps during this, going upstairs. But what it would look like would be and we would get them to maintain that same rhythm. We probably initiate this technique without activity at first, and then progress it to activity once they've shown a mastery of the technique. And that was it.